we are a center that follows cardiomyopathy since 30 years. And we had in the past as chief Claudio Rapetti, that was a very important professor in collecting and developing all the knowledge about amyloidosis. Now I'm going to present you my team that is composed in this case of 3 people that are following amyloidosis, patients with amyloidosis. We have, they follow more than 400 patients alive at today. And the most are TTR amyloidosis, and specifically around 150 wild type, 100 mutated, and 150 AL. And the webinar will start with ERN GUARD-Heart, who is going to present a clinical case about diagnosis. Then Giulia Saturi is going to present a point of view about diagnosis. Then again, Irene will present a case about diagnosis, and Simone Longhi will finish with a lecture about therapy. Of course, questions are very welcome in every moment, and we will answer in every moment to your questions. So now I'm going to introduce Irene, and Irene is going to present to you a clinical case.
Good morning to everyone, and thank you, Elena, for the presentation. I'm going to talk about the clinical case number 1, about how to diagnose cardiac amyloidosis. I'll talk about a 78-year-old man affected by hypertension and with an history of frequent premature ventricular beats with a right bundle branch block morphology. He had no other relevant comorbidity in his past clinical history. In February 2020, he has been hospitalized for a first episode of heart failure at another center. He has been admitted to hospital for a worsening fatigue and shortness of breath and progressive fluid retention. At the time of the admission, he had oxygen desaturation requiring oxygen therapy. And as you can see, the chest X-ray showed pulmonary congestion and troponin and NT-proBNP values were particularly high. The electrocardiogram showed the sinus rhythm with supraventricular premature complexes and a first-degree atrioventricular block with no other relevant features. Here you can see the echocardiogram with a normal volume of left ventricle, and you can also see a mild concentric left ventricular hypertrophy with a mild hypokinesia, and it is more evident to the basal inferior posterior segments. We can also see a reduction of the medial S wave and the global longitudinal strain and a first-degree diastolic dysfunction. Notably, aortic and mitral valves appear to be thickened with no significant regurgitation, and we can also see a thickening of interatrial septum and a mild pericardial effusion. The coronary angiography excluded coronary lesions, as you can see. A cardiac magnetic resonance has been then performed, confirming the echocardiographic findings of mild concentric left ventricular hypertrophy with a mild hypokinesia and ejection fraction of 41% of left ventricle with a severe hypokinesia of basal segments. We also saw normal volume of right ventricle with ejection fraction of 41%, and notably CMR also showed mid-wall circumferential late gadolinium enhancement in middle and basal segments. So in summary, we have a 78-year-old man with a recent hospitalization for heart failure and an hypertrophic cardiomyopathy phenotype, but in patient with a high blood pressure history. So on one hand, we have a mild reduced ejection fraction heart failure with an evidence of apical sparing without coronary lesions. And on the other hand, we have an history of premature ventricular beats and an LGE ring-like pattern at the cardiac magnetic resonance. That's why our colleagues suspected arrhythmogenic cardiomyopathy. So they sent the patient to our cardiomyopathy center, where we started an hypertrophic cardiomyopathy phenotype diagnostic workup. That's why we performed the dry blood spot to rule out Anderson-Fabry disease, blood and urine immunization, and free kappa and lambda chain to rule out AL amyloidosis. And finally, we detect a heterogeneous score 2 at the DPD bone scintigraphy, which is suggestive of transthyretin cardiac amyloidosis. So in the end, we performed also a genetic blood test, which showed a mutation of a transthyretin gene, the E68L mutation. That's why we also performed a neurological assessment showing carpal tunnel syndrome and inferior limbs sensory polyneuropathy, which suggested the diagnosis of hereditary transthyretin cardiac amyloidosis with also neurological involvement related to the mutation E68L of transthyretin.
Okay, thank you, Irene, for this clinical case. In this first part, we will talk about the diagnosis of cardiac amyloidosis. As well known, cardiac amyloidosis is a systemic condition caused by the misfolding of a protein, which infiltrates in fibrillar form into various organs and tissues, including the heart, leading to the development of irreversible restrictive cardiomyopathy. The most common form of cardiac amyloidosis are three: TTR wild type, TTR mutated, and light chain amyloidosis. The prevalence and the incidence of cardiac amyloidosis have been exponentially increasing in recent years. Once considered a rare disease, it is now more frequently suspected and diagnosed. This epidemiological revolution is due to two conditions. The first is the availability of non-invasive diagnostic algorithm, and the second reason is the availability of disease-modifying therapies. In 2021, the first position paper regarding the diagnosis and treatment of cardiac amyloidosis was published on the European Heart Journal, and this statement focuses on three aspects: the diagnostic suspect, the diagnostic criteria, and the treatment. The diagnostic suspicion is based on echocardiographic evidence of left ventricular wall thickness major than or equal to 12 millimeters, in addition to some cardiac or extracardiac red flags. Some of these red flags were present in our clinical case, such heart failure above 65 years old, normotensive patient previously hypertensive, peripheral polyneuropathy, bilateral carpal tunnel syndrome, the presence of late gadolinium enhancement at cardiac MRI, a reduced longitudinal strain with apical sparing, and atrioventricular conduction disease at EKG. Previously, the diagnosis was based exclusively on histological criteria, necessitating a biopsy of myocardium or of extracardiac tissues, and after immunostaining and genetic test will lead to definite diagnosis. Currently, we have two possible strategies for the diagnosis of cardiac amyloidosis: an invasive strategy based on the extracardiac or cardiac biopsy, and a non-invasive diagnosis based on the Gilmore algorithm. This is the algorithm for the non-invasive diagnosis of cardiac amyloidosis. So in the presence of signs and symptoms, an EKG, an echocardiogram, or a CMR suggested for cardiac amyloidosis, we need two more tests. Total body bone scintigraphy with the DPD, PYP, or HMDP tracer, and a hematologic test, which includes serum-free light chain quantification and serum and urine immunofixation. And then we can have four scenarios. The first scenario is the one in which we have a grade 0 scintigraphy and a negative hematological test. In this case, a diagnosis of cardiac amyloidosis, both AL and TTR, is very unlikely, but if the clinical suspicion is high, we can consider a CMR followed by a biopsy. The second scenario is the simplest. We have a positive scintigraphy and a negative hematological test. In case of moderate or intense uptake at bone scintigraphy, so Perugini grade 2 or 3, we can have a definite diagnosis of TTR cardiac amyloidosis, and then we will perform a genetic test to distinguish between the wild type and the mutated form. If we have a mild uptake at bone scintigraphy, so a grade 1, we need an histological confirmation in cardiac or extracardiac tissue to have the diagnosis. In the third scenario, we have a negative scintigraphy, but positive hematological test. So the suspicion is a light chain amyloidosis. And then we have to perform a CMR. If the CMR is negative, the diagnosis of amyloidosis is very unlikely. But if we have a positive or inconclusive CMR, we need histological confirmation. Finally, in case of positivity of both scintigraphy and blood test, biopsy is necessary to define the subtype of amyloidosis. The possibility of a non-invasive diagnosis depends on the discovery here in Bologna of the cardiac uptake of bone tracer at total body bone scintigraphy, which is graded with the Perugini score. A score 0 indicates the absence of cardiac uptake. A score 1 indicates a mild cardiac uptake. A score 2, a moderate cardiac uptake with attenuation of the bone signal. And a score 3 is a elevated cardiac uptake with a zeroing of bone uptake. On this discovered, the Gilmore algorithm was based. It was published in 2016, and it confirmed a high sensibility and specificity of bone scintigraphy in transthyretin cardiac amyloidosis. And if we have the association of a moderate or intense uptake at bone scintigraphy with the absence of monoclonal protein, this test has a positive predictive value around 100%. We have seen the non-invasive diagnostic algorithm, but we know that the invasive diagnostic algorithm has still an important role for light chain amyloidosis. Maybe in the future some other tests could lead to a non-invasive diagnosis also in this case. In particular, we have already seen the importance of MRI. The MRI is crucial in doubtful cases to discriminate between suspected amyloidosis and other hypertrophic cardiomyopathy. But it seems that different U1-T2 mapping, different extracellular volumes may differentiate between light chain amyloidosis and transthyretin amyloidosis. In addition, positron emission tomography has found the clinical utility in the diagnosis of cardiac amyloidosis in recent years. Specifically, some amyloid tracer, such as florbetaben, could distinguish between transthyretin and light chain amyloidosis. Thank you very much.
Thank you very much, Giulia. I don't know if we have already some questions. Maybe not. So Thank you for this very complete diagnostic flowchart about diagnosis. Now Irene again will present to you a clinical case about therapy.
Thank you, Elena, again. Let's go to clinical case number 2 about how to treat cardiac amyloidosis. It concerns a 54-year-old man with an history of gastroesophageal reflux disorder and no other relevant comorbidity in his past clinical history. In 1998, when he was 34-year-old, we detected a TTR mutation, the G47A mutation, during a family screening because his mother was affected by hereditary ATTR with the same mutation. We performed then a regular follow-up, and between 1998 and 2008, we didn't find any clinical and instrumental pathological findings. In 2008, at the age of 44, we detected initial findings suggestive of cardiac amyloidosis. That's why we performed the bone scintigraphy, which showed the Perugini score 2, and then also, endomyocardial biopsy, showing amyloid deposits in interstitial and subendocardial location, and the positivity for TTR at immunochemistry. In the next years, the patient had a worsening of cardiac involvement. Here you can see a 2011 echocardiography showing a moderate concentric left ventricular hypertrophy, a normal ejection fraction of left ventricle with a reduced medial and lateral S wave, and the second-degree diastolic dysfunction. In 2013, the patient developed the peripheral and autonomic symptoms, and he was diagnosed with a polyneuropathy. That's why he started tafamidis by neurology indication. In the next years, the patient experienced a worsening of neurological symptoms, and in 2018, we also detected a further progression of cardiac involvement. Here we have a 2018 echocardiography, which show severe concentric left ventricular hypertrophy, a normal ejection fraction of left ventricle with a reduction of medial S wave and global longitudinal strain with an evidence of apical sparing. In the same year, 2018, the patient has been evaluated for combined heart-liver transplant, but the option was excluded because of progressive severe chronic kidney disease and neurological impairment. That's why we started the treatment with the patisiran for compassionate use. In the next years, between 2018 and 2020, the patient experienced a mild improvement of neuropathy and a substantial stability from a cardiovascular point of view. In the next years, he unfortunately died because of the end-stage pathology. So
now we will go to Simone Longhi, that will complete the presentation with a small lecture about the treatment of amyloidosis.
Okay, thank you, Elena. In the next few minutes, we are talking about treatment. Okay. So the management of patients affected by cardiac amyloidosis includes supportive care, as you can see, optimization of fluid status, loop diuretics, anticoagulation in atrial fibrillation, as well as the histologic treatment according to the subtype of amyloidosis. In AL amyloidosis, chemotherapy is the treatment, and the goal is to normalize the involved free light chain. The first step in the treatment of patients affected by AL amyloidosis is the evaluation of eligibility of stem cell transplant. If yes, induction should be performed with daratumumab, a human monoclonal antibody, cyclophosphamide, bortezomib, and desamethasone, and then a stem cell transplant could be performed. According to the response, a complete response or partial response, we have a different follow-up of the patients. If the stem cell transplant is not possible, a combination of chemotherapy could be performed. And once again, according to the response, complete, partial, we have a different follow-up of this patient. But in the recent years, the great interest in cardiac amyloidosis is TTR amyloidosis and treatment of TTR amyloidosis. The first treatment was liver transplantation, because as you know, more than 90% of TTR is produced by liver. But now this treatment is not so performed for almost 2 reasons. First of all, progression of the disease. Amyloid involved in organs calls amyloid from the new liver, so a nest effect. Moreover, the availability of organs, and this treatment is not the real treatment of patients affected by wild-type amyloidosis, who are the most part of our patients. So now we have different drugs that we can use to stop the progression of the disease through knockdown of mutant and variant TTR, stabilization of TTR, and removing misfolding TTR. So now we analyze TTR stabilizer. The first TTR stabilizer is tafamidis. Tafamidis preventing tetrameric dissociation and amyloidogenesis. And in the ATTRACT study, all-cause mortality and cardiovascular-related hospitalization were less evident in patients treated with tafamidis compared to placebo. And the survival curves were different at 18 months. And at the end of the study, at 30 months, patients treated with tafamidis have lower decline of 6-minute walking tests and lower reduction of North Kansas City questionnaire score. The long-term extension study showed that patients treated with tafamidis in the ATTRACT study have a better survival, as you can see here in red, compared with a patient treated in placebo in the ATTRACT study. So a great importance, early diagnosis and start treatment as soon as possible in these patients. Another TTR stabilizer is acoramidis. Acoramidis is a strong tafamidis with a high affinity for transthyretin. In attribute cardiomyopathy trials, patients treated with acoramidis have a great important outcome of 4-step composed of death from any cause, cardiovascular-related hospitalization, change from baseline in NT-proBNP, and 6-minute walking test. Once again, the survival curves are separated at 90 months, like tafamidis, with a good profile, safety profile. Then we analyze the knockdown mutant and variant TTR. The first analysis is patisiran. Patisiran is a small interfering RNA approved for the treatment of patients affected by TTR amyloidosis with polyneuropathy. In this study, the APOLLO-B study, we analyzed patisiran in the cardiovascular setting in patients affected by cardiomyopathy and TTR and familiar TTR amyloidosis or wild type, randomized to receive patisiran, intravenous patisiran every 3 weeks or placebo. And patisiran show a preserved functional capacity of patients treated by our patisiran compared with the placebo, as you can see in 6-minute walking test and in neutral quality of life with a good safety profile. So there are a new chemical modification of patisiran, vutrisiran. Vutrisiran is analyzed in this Helios study, in which patients affected by transthyretin-related amyloidosis with polyneuropathy were randomized to receive vutrisiran, a subcutaneous administration of vutrisiran every 3 months, compared to placebo. And once again, but vutrisiran had a good clinical profile, with a stop to the progression of neurological involvement of the disease when compared to placebo. And we are waiting for the results of vutrisiran in a cardiovascular setting. The results are expected early to 2024. Moreover, inotersen is an antisense oligonucleotide was approved for the treatment of patients affected by transthyretin-related amyloidosis, familial hereditary amyloidosis with polyneuropathy. And a chemical, once again, a chemical modification of this drug, eplontersen, was analyzed in patients affected by familial TTR with polyneuropathy. And we can see in yellow, a reduction of TTR, serum TTR concentration in patients treated with eplontersen, and once again, a stop of the progression of the disease from the point of view, from neurological point of view. And once again, we are waiting for the results of eplontersen in a patient affected by cardiomyopathy and familial amyloidotic TTR or wild type. This is probably the most important study in this period because it more than 1,000 patients were enrolled. So we are waiting for the results of this trial. And finally, removing the misfolding TTR. In these phase 1 trials, an antibody against TTR infiltrating the organs can reduce the concentration of amyloid in the heart, as you can see here at scintigraphy, cardiac tracer at baseline and cardiac tracer after administration of the antibody, as you can see in the reduction of extra volume on a cardiac MRI. Moreover, we observe a reduction in NT-proBNP from baseline to after 12 months of administration, and the value of troponin. So, in conclusion, we have different drugs for different etiology of TTR. In a wild-type amyloidosis, in which cardiomyopathy is the most important, or probably the only manifestation of the disease, tafamidis is recommended. In patients affected by familial amyloidotic TTR with cardiomyopathy only, once again, tafamidis is recommended, but if we have a polyneuropathy or a combination of cardiomyopathy, we have tafamidis, patisiran, or now vutrisiran, inotersen, or now eplontersen, and so on. Thank you for your attention.
Thank you very much, Irene, Giulia, and Simone. I can start with some questions to you. Giulia, you could maybe tell us better what are the clinical indications for myocardial biopsy, and also when myocardial biopsy is not enough to define the precise etiological diagnosis, because we find both TTR and AL protein, so what to do in these complex cases?
Thank you, Elena, for your question. Endomyocardial biopsy is still an important exam in 2 cases. To define the presence of amyloid deposits, if we have a high clinical suspicion, but if we have a negative bone scintigraphy and negative hematological test, so with the typical Congo red staining and apple green beer infringence, we can demonstrate the presence of deposit. And it is also important for the etiological diagnosis in cases of suspected light chain. And if we have the positivity of both scintigraphy and hematological test. In this case, in fact, we can have a TTR amyloidosis associated with MGUS or a light chain amyloidosis with a false positive in the scintigraphy. And the etiological diagnosis is very important to have the correct therapy. But when we perform the biopsy, the first step is to demonstrate the amyloid deposits, and then we need to characterize this deposit with immunochemistry. So with antibody, again, TTR or light chain, but in some cases this is not clear. So we can have a positivity both for TTR and light chain, and so we need to perform a mass spectrometry examination that can lead us to the definite etiological diagnosis.
Thank you, Julia. I see there is a question from Peter for Zwetslot, Erasmus in Rotterdam. When do you refer to other specialists? Do you have ATTR mutation specific immediate referrals to neurologists or ophthalmologists, or do you only do this when there are complaints? So,
okay, thank you for the question. Here in Bologna, we have a multidisciplinary group of us with a cardiologist, with a cardiological interest, neurologist, and ophthalmologist. So, patients affected by TTR, hereditary TTR, are evaluated at the same time from cardiologist, neurologist, gastroenterologist, and ophthalmologist. And so all patients with TTR mutation are evaluated.
Okay. And Simone, just again to you, what do you think about the indication to medical therapy? Do you think that the now available indication are enough, or you would prefer to, you think that it would be better to start therapy earlier, or what about a combination of therapy?
Thank you, Elena. I think that the combination of therapy could be the future of the treatment of TTR amyloidosis. But now we are not
in which cases? In all cases, or specifically?
Probably in all cases, in all cases of hereditary amyloidosis. But the results of all the trial I showed probably could obtain an ampliation of this indication. And regarding the time of treatment, I think that probably the early diagnosis conduces to an early start to treat these patients, because first we can start to treat this patient, and better is the results of the drugs. So,
would you suggest to base more on NIHA class or hypertrophy, organ damage?
It's not a, thank you, Elena. It's not an easy question. Probably an age class is the first recommendation. In Italy, for example, we can use for tafamidis for wild type TTR only in NIA class 1 or 2. So, for example, the NIA class 3 are out of this treatment. And it's quite difficult to use other therapies in this setting.
Yes, And the other consideration about combination therapy is the cost effectiveness problem that indeed is something we have to consider because these patients are not so rare anymore.
No.
Are there any other questions?
Helena, may I ask a question? I mean, from Amsterdam.
Sure.
With regard to what was asked before, as you're, this is incredible work what you're doing, and it's really a team of experts needed. Do you have numbers of how often patients are referred to your center with a false diagnosis or a misdiagnosis of amyloidosis? How often is this diagnosis missed? Actually, is the question.
Thank you for the question. I think that the amyloidosis is found when we look for amyloidosis. So there are a lot of patients who are followed for hypertensive cardiopathy or hypertrophic cardiomyopathy. And then if we look together to the echocardiogram, EKG, the history, the extracardiac red flags, we can suspect amyloidosis and so do the correct test. So yes, we have not a lot, but some misdiagnosis of amyloidosis. And we hope to reduce this number with the education of cardiologists and of internal medicine about the presence of amyloidosis, the suspicion of amyloidosis.
Thank you. And I had another question with regard to conduction disease in amyloidosis. As you know, I mean, there are quite some number of patients who have to receive a pacemaker because of conduction disorders, in especially the hereditary form of amyloidosis. Are you aware of any patients with isolated conduction disease before a clear manifestation of the disease on myocardial level? So that's first level of conduction disease at AV nodal level, and then the diagnosis is established. The reason I ask is because we do have in our inherited outpatient clinic, we do receive often patients with conduction disease at the age of 50, 60. So and often they have hypertension, so we give them a pacemaker without any further evaluation for really amyloidosis. So that's why I asked this question.
Yeah, and thank you very much for this question. This is very interesting for us. We have conducted a study about pacemaker in amyloidosis patient, and in effect, we have 10% of the patient followed in our setting who arrived to us after a pacemaker implantation. So 10% it's a high number. And maybe it is also higher, but we have also misdiagnosis of hypertensive cardiopathy. So I think that when we have a conduction disease, even if the patient is hypertensive, so we can suspect hypertension, a normal hypertension, and a conduction disease due to aging. We have to suspect amyloidosis also because we can have the diagnosis non-invasively, so we have no excuses not to perform the test needed.
I don't know, Julia, if Amin was wondering also if we see any patients with atrioventricular block before hypertrophy.
This is a difficult question because I don't know really, because if we don't have hypertrophy or acceptance thickness above or equal to 12 millimeters, it is difficult to that other tests are performed. So I don't know. In a mutated patient in the carrier, we don't have cases of pacemaker implantation before the development of cardiomyopathy, but maybe yes, maybe this is possible.
If you reconstructed the history of the patient when it comes to our center and he already has a pacemaker since some years before, you don't know if he had hypertrophy or not at that time.
Yes.
Or probably patients affected by hereditary TTR amyloidosis, VAL 30-MET. When we can document it an atrioventricular block, even if a great hypertrophy.
Okay. We want to develop a conduction disease panel of genetic panel for testing in patients with AV block. And we wondered if we need to include TTR in that panel for patients with isolated AV block. But I couldn't find a paper about this. So with TTR mediated AV block without any systemic manifestation of amyloidosis. But if I understand, you have some patients with V30M mutation who do have AV block without hypertrophy.
Very few is an exception.
Yes, I think, I mean, if you are speaking about screening, you know, in patient with AV block, it's probably similar to Fabry disease. It's difficult to find patients with this specific diagnosis in this setting. And especially in amyloidosis, probably hypertrophy and conduction defect are going together. So probably it's different from Lamin or Desmin, where it has a meaning to screen this patient for these genetic defects. I think in infiltration and storage disease is probably different. So it's quite rare to have only conduction defect, except for of course in Fabry patients that are females, where since it's an X-linked disease, it's rare but not impossible. But the only paper that was published found 0% of Fabry patients in that setting. In amyloidosis, I don't think there are any papers about this screening.
Thank you.
I don't know. I think that if there are no other questions.
No, I don't see any questions in the chat anymore, and I see no hands raised. So I think we can come to an end. It's almost 1:45. So I would like to thank you, Simona, Julia, and Irene for your presentations, and of course Elena for helping us creating the nice program for this edition. And we hope to, thanks to the participants, of course, and we hope to meet you next month again. And have a nice day.
Thank you very much.
Thank you very much.
Bye-bye.
Bye-bye.
Bye.
Bye.
Bye.